Hello, and thank you for attending today's webinar, Lung Safety and Disease Progression in Non-Respiratory Trials, presented by ERT. Before we cover a few housekeeping items, at the bottom of your audience console are multiple application widgets you can use. You can click on the Q&A widget at the bottom and submit your question. We will try to answer.
Hi, hello everybody. Thank you, Chris, for introducing me. I was just hesitating for a small second because I could not hear you, Chris, during your last sentences on the live presentation. So if you can hear me, that would of course be,
I can hear you, Kai, and you're live with our audience. All good.
Oh, that's wonderful to hear. Okay, great. So it's good to hear everybody. Welcome everybody to this interesting webinar that we have today. We have got something quite special today, and of course for me as a pulmonologist, it's always a big pleasure to focus people's attention, people who are working in drug development, clinical research, in other parts of the human body, which is not exactly the lung, but to make them aware that the lung is not only a very fascinating organ to study if you choose a medical profession, but it's also a very interesting organ when it comes to other disciplines of medicine, as the lung is a disease, is very often affected by multiple other diseases, but it also may be a very important target organ for issues that relate to lung safety. And that is the main agenda and context of my webinar for today. So we will look at this talk on the lung as a target organ for both toxicity or, in a more broader sense, tolerability in drug development. We will look at some of the typical patterns of pulmonary drug reactions, what these potential reactions mean in terms of their implication for monitoring. And then in the second part of the talk, we will look at some examples of the many which are out there, some examples on how the lung can actually be affected by diseases which have a systemic component and may actually impact on pulmonary function, which also has implication for not only monitoring patients, if you're, for example, working in neurology, immunology, or rheumatology, but also this may have implications for the prognosis of patients, and it may be an important outcome parameter when it comes to drug development or clinical research. So we'll also look at the prognostic relevance of lung involvement in some of these diseases and discuss the potential use of pulmonary function as a relevant clinical outcome parameter in clinical trials. And then finally, of course, we will have a Q&A session, which will then be moderated again by Chris. So the lung as a target option for toxicity or tolerability can be affected in multiple ways. The obvious is, of course, that the lung can be the delivery route for inhaled particles or inhaled drugs. Most of them, of course, are used to directly treat the lung. So we're using inhaled drugs to treat airway diseases like asthma or COPD, which usually constitutes of bronchodilators or anti-inflammatory drugs like inhaled corticosteroids and stuff like that. But, of course, the inhaled route to the lung can also be used as a vehicle to treat non-pulmonary conditions by using the lung as an entry organ. And there are examples like the attempts to deliver insulin through the lung in diabetes. There's also now some attempts going on with vaccination through the lung, or in general using the lung as an entry for drugs that are used to treat systemic diseases. And then finally, of course, the lung is also exposed to systemic toxicity of drugs, or in a broader sense, interventions. So the lung is, of course, reached by 100% of the bloodstream, one of the few organs where actually 100% of the circulating blood volume is passed through. And the lung can also be, if you like, accidentally exposed to interventions, for example, like radiation, where the lung is just exposed to the procedure by means of anatomy. There are different parts, different patterns of pulmonary drug reactions. Most of them fall into more or less 4 categories. The most prominent form of recognized pulmonary drug reactions are diffuse parenchymal lung diseases. And I will talk about that later in a bit more detail. So these are diseases that manifest themselves as interstitial lung diseases with all their clinical and pathophysiological consequences. There is also a broad number of drugs that cause bronchospasm as a consequence of unwanted medical or drug effects. Then we have a group of medications that can be associated with pulmonary vascular disorders. And an infamous example is drugs that, for example, cause pulmonary arterial hypertension by increasing pulmonary vascular resistance. And then finally, there is a more inhomogeneous group of drugs that can have a variety of pulmonary symptoms or side effects. Cough, for example, is frequently associated with ACE inhibitors for hypertension, but there also may be side effects that affect the neuromuscular drive of breathing and stuff like that. About 70% of reported cases, which does not mean that this is really reflecting the true situation of tolerability in the lung, but about 70% of reported cases refer to interstitial lung disease or parenchymal lung disease. Now, why is pulmonary drug toxicity important, and how does that actually happen? Well, in principle, one thing that can happen is simply that the drug that you give produces an unwanted receptor activation. So the classical example for that is you use a drug that, for example, antagonizes the function of the beta-2 receptor and then directly causes via G protein-coupled mechanism a bronchoconstriction. That's obvious. For most other drugs, there are 3 different biomechanisms which can lead to cell damage, cell death, inflammation, and in the end, tissue damage. The first is bioactivation, which is more or less the same that happens with drug transformation or drug bioactivation in the liver. So the detoxification for metabolism of drugs. Usually during this type of bioactivation, which also happens in the lung, so the lung is also active in drug metabolism. During this bioactivation, normally as a first step, some type of intermediate products of the drug are generated. Very often in this process, reactive oxygen species or reactive intermediate metabolites are generated, and they can cause oxidative stress. There are, of course, a number of drugs that have direct cytotoxicity, anti-cancer drugs, anti-metabolic drugs, or whatever. And they, of course, can cause direct cell damage, particularly also in the lung. And then finally, there are a group of drugs that cause a direct immunologic response involving adaptive immunity, antibody production, and B-cell and T-cell mediated inflammatory processes in the lung. So a wide pattern, but in the end, down the road, you get oxidative stress, you get cell death, and you get a disturbed inflammation repair cycle in the lung. Why in the lung? For some drugs, it has been shown that there is distinct and specific accumulation of drugs within the lung. Famous examples are amiodarone, which is used to treat cardiac arrhythmias, and a drug which is more used in is a herbicide, which is used in farming situation, is paraquat, which has also been shown to be specifically accumulated in the lung. Then there is a specific lung bioactivation, which may be different from the liver, and we know that there are, for example, genetic differences in different people, how these bioactivation processes can occur. And this can also be one reason why a drug toxicity can occur exclusively in the lung, while on the same time not affecting the liver, which is the primary organ for detoxification, and therefore, by physiological logic, if you like, should be always the first organ for drug toxicity, because that's the first hand of exposure to these types of drugs. And then finally, of course, there is a specific environment which makes the lung unique. First of all, the environment of the lung can be altered because there may be an underlying disease. So there may be an established type of interstitial lung disease or an airway disease. There may be allergy, infection, or pre-established inflammation, which changes the interaction with the other mechanisms of bioactivation of drugs or deactivation of drugs. And of course, there is a particular hazardous association in the lung, which is related to the high concentration of oxygen due to the physiological function of the lung. And of course, oxygen per se can be toxic, and oxygen, and particularly free radicals of oxygen, in conjunction with reactive intermediate metabolites of drugs, can be a potential hazard for the lung, and thus increasing the risk for pulmonary drug toxicity. As I said, the most frequent adverse effect in the lung is interstitial lung disease. So what does that mean? Now, this is a magnification or illustration of the alveolar space. So that's the part of the lung which is the very most distal part of the conducting airways, the part where there's more or less only a single cell layer of alveolar cells, closely connected to the capillary endothelium, so the bloodstream, and this is the part where the oxygen exchange actually happens, the gas exchange between oxygen from the bloodstream to the air and vice versa, and on the other hand also the exchange of carbon dioxide from the bloodstream out into the exhaled air. That's a very sensitive area. It's a very thin layer, and it contains a lot of connective tissue, and it's got a high oxygen tension, and this is why this particular area is very vulnerable to pulmonary drug toxicity. There are hundreds of agents where at least there are case reports of suspected pulmonary drug reactions within the pulmonary interstitium, and that ranges from cytotoxic agents like typical anti-cancer drugs, but also a number of non-cytotoxic agents like, as I said already, amiodarone, but also a number of other drugs that have been associated with the occurrence of acute, subacute, or chronic interstitial lung diseases. All over, there are currently more than 350 agents that have been reported to be potentially implied. One more recent example is the example of EGF inhibition to treat cancer. It's a relatively rare but potentially life-threatening complication of EGF inhibition, which causes a interstitial lung disease, which is very often characterized by diffuse and acute alveolar damage, and that can be life-threatening for patients. And as you see by a frequency distribution on the left hand of the table, you can see that there are marked differences in the occurrence of such adverse events through populations, indicating that there's obviously a genetic background in the bioactivation and metabolism of these drugs within the lung, for example, for EGF between Asians and Caucasians or the rest of the world, because in Asia or in Japan, the occurrence of this type of interstitial lung disease with EGF inhibition is about twice as high, and also fatality is at twice as high as in the rest of the world. And that, of course, has got some implications for monitoring, because as these drug toxicity can potentially be life-threatening, the best way is to recognize it early, terminate the exposure to the drug, and then hopefully, and in most cases successfully, terminate the clinical course of the interstitial lung disease. The clinical patterns range from acute, as I said, acute interstitial lung disease that can occur within hours after drug exposure to days, which is usually a very dramatic clinical picture involving severe dyspnea, chest pain, crackles all over auscultation, and then very often leading to rapid respiratory failure. What is more frequent is a more subacute, prolonged or chronic onset, which goes over months or years, which sometimes makes it quite difficult to actually make the connection between the drug exposure and the occurrence of interstitial lung disease. If that occurs years after the exposure, very often these cases probably, if you don't take a proper history, would go unnoticed or would probably be labeled as idiopathic pulmonary fibrosis. However, if you dig deep in the history of your patient, very often you find something like exposure to a potentially to a drug that potentially induces interstitial lung disease. There are different tools how to monitor the occurrence of such a relevant side effect of a drug. Chest X-rays can be used, but are very insensitive, particularly when it comes to early or let's say less pronounced changes within the interstitium. A chest X-ray would probably only respond to a more extended capillary leak and then fibrosis. High-resolution CT scans are, of course, much more sensitive. You can directly scan the parenchyma, but of course that's more cost-intensive. It has exposure to radiation, and it's not suitable to use it in serial measurements over short periods of time. So that's also not the first thing to study. Pulmonary function tests are very important in that regard because there are some of them, of course, are very sensitive to early changes in the lung parenchyma when it comes to side effects of drug or drug toxicity. Particularly diffusion capacity is very sensitive, a sensitive indicator of a disturbance of gas exchange. But there are also others. Spirometry response, because these interstitial changes sooner or later, as a consequence, lead to a restrictive ventilatory impairment pattern. So volumes of the lung get decreased, which can also be detected by plethysmography. Then, in the end, this will lead to abnormalities in the arterial blood gases. So measuring blood gases, particularly in conjunction with exercise, is also a good indicator of a disturbance of the gas exchange. There are some blood tests in some regions of the world, particularly Japan, where there's some experience and also some routine use of specific alveolar leakage or alveolar damage markers, which may be serum KL6 or surfactant protein D, which are also increased in the bloodstream of patients that have alveolar leak or interstitial damage. And then, of course, finally, there are more invasive measurements like biopsies or lavage to really make a definite diagnosis of an interstitial lung disease in conjunction with exposure to a drug. So in practice, diffusion impairment is central for monitoring these safety signals. It's the most sensitive, and diffusion impairment can best be measured by measurement of diffusion capacity, and usually is complemented by a simple spirometry where you can see whether a patient has got a restrictive pattern, a restrictive impairment of lung function, which is also indicative of a process involving alveoli or the interstitium of the lung. As I said, DLCO is very important, which is nothing else than the diffusion capacity for carbon monoxide. Carbon monoxide in this test, which is a very simple test, it can be standardized. It can also be used in a centralized approach in multi-center international clinical trials. It's actually a test which involves only, well, a few minutes of effort, and it uses CO as a test gas to measure the ability of gas to diffuse from the air into the bloodstream of a patient. So in simple words, the patient is inhaling a very low concentration of carbon monoxide, which will then pass the alveolar membrane into the bloodstream. Then the patient will exhale out. You will collect the gas, and then you basically compare the concentration that went into the patient and the concentration of CO that went out of the patient to get an idea of how the diffusion of CO is managed within his alveoli. There are many advantages to that because CO normally is not found in the human body. So you can use that. You can assume that in most people CO in blood is 0, and that makes the calculation of the diffusion capacity on an individual level much more easier, as if you take a different gas like helium or oxygen or something like that. So a very simple test, and it gives you a good idea of how diffusion works in somebody who has a suspected or potential exposure to a drug which may cause lung damage. There are also some algorithms in the literature how to follow up on patients and to monitor patients for parenchymal pulmonary drug reactions, for example, not only in clinical practice but also in clinical trials. It is recommended that there should be regular DLCO measurements, ideally every 3 months, maybe every 6 months, depending on the degree of, let's say, toxicity or the degree of suspected potential of your drug to cause parenchymal disease. If you have a normal DLCO or an unchanged DLCO, then there is a recommendation to repeat that in, let's say, 2 to 3 months. If there is an abnormal DLCO value or, let's say, a 10 or 15% decline in this diffusion capacity from baseline, a further follow-up is recommended to use a spirometry to measure vital capacity. If that is normal, you really want to exclude that there is some issue with pulmonary gas exchange. The next test would be blood gas analysis with exercise, which is also very sensitive and a very good reflector of the uptake of oxygen under exercise condition and very early indicates if there is an impairment. However, if also the vital capacity is abnormal, that is very suggestive already of an established interstitial process, and that would require further workup, for example, with a CT scan, but also potentially with a biopsy or lavage. Now let's look at some of the examples in drug development over the last, let's say, 10 or 15 years, where some of these issues can be followed through the development process. One example is the development of inhaled insulin, Exubera, which was developed in the 90s and early 2000s to be an alternative option for patients with diabetes to get insulin into their body. So there are several issues to consider when it comes to inhaled insulin. First of all, it's administered via inhalation, where that was the whole purpose of the exercise. But it's a chronic disease, so it's also very important that one should note that this would be a lifelong, or at least a year-long or decade-long chronic administration. And then other pathophysiological factors come into effect, which is that insulin, notably as a protein, is associated with a potential immune response of the body. And second, insulin in vitro, in vivo, has shown to have growth-promoting properties. So those who developed insulin as an inhaled formulation were faced with the fact or consideration that they should make clear that there is no something like a pulmonary inflammation going on, airway inflammation that would lead, for example, to obstructive airway disease, and whether there would not be any growth of, for example, connective tissue, fibrosis, interstitial lung disease, and of course cancer. And that meant that in this drug development process, there was a consecutive and consequent monitoring of pulmonary function parameters. So the airways were covered by using, in the phase 3 trials, regular spirometry, looking at FEV1, which is the parameter that best reflects airway patency and would rule out the effect on insulin on any obstructive lung disease or promoting obstructive lung disease. And second, the parenchymal compartment was monitored by using not only spirometry in volumes, but also in addition with using regular diffusion capacity to rule out that there would be a progressive impairment of the alveolar membrane, disturbing oxygen exchange by the continuous inhalation of insulin. So this is what they did here. Example, you don't have to look at the detail. It's just giving you an idea that over this study, for example, 24 months, 2 years, there was consecutive measurements of lung function. You can also see that in green, insulin had a slight decrease in lung function compared to those who were treated with sub-Q insulin, but that was in a magnitude of 50 ml, something like that, which is probably not in a range of being clinically relevant, but that's not the issue to discuss. It just gives an example that it is necessary, maybe necessary, to monitor that over the long-term course to have a convincing point that your drug is not posing any safety issues on the patient that uses insulin for treatment of diabetes. And also, at the same time, they used diffusion capacity in many centers. So again, you can see here there was a 12-week treatment period and then a 12-week washout period, and you can see that yes, in fact, using inhaled diabetes in green decreased pulmonary diffusion capacity, which is not you look at the scale, that's actually not a big effect, but anyway, you can see that there's something going on, and if the drug was discontinued, that normalizes again. So there was some effect, but the effect was reversible when the treatment was discontinued. So a typical example for using that in clinical drug development. There are now currently also other studies going on in drugs that do not target the lung but have potential lung toxicity. So this is taken from clinicaltrials.gov. This is just a simple example of a multiple sclerosis trial, phase 3, which will use an investigational drug versus a placebo in patient with secondary progressive multiple sclerosis. And you can see that part of the safety follow-up of these patients, very importantly, in this multiple year long-term study will be the close monitoring of both spirometry, FEV1, forced vital capacity, but also diffusion capacity, DLCO, and that's going to be done with a centralized measurement provider. Final example, I mean, this is all in parenchymal drug disease, so it's more or less toxicity of a drug to the alveolar membrane. A different part of, let's say, an issue with tolerability is anything that may have an impact on the neuromuscular drive of breathing. So it's not all about the lung being functional, which is also very important, is the muscles that actually perform the work of breathing. They also can be affected. So one example of the drugs that are currently, let's say, a little bit in focus is Botox. Botox is, of course, a drug that is widely used for cosmetic purposes, and it's derived from a toxin of a bacterium, this Clostridium botulinum. Now, basically what this drug does is to reduce muscle activity. So it paralyzes muscles by blocking nerves. And that has, whatever you use it, different consequences. If you use it on your wrinkles in the face, that means you get a better look, or you can doubt whether this is a better look, but let's say you get a different look. But, of course, the drug can also be used, apart from cosmetic purposes, to treat other diseases. It's approved for treating migraine or different types of muscle spasticity, and also in hyperhidrosis. Now, there is a lot of investigations going on now with Botox, trying to use this drug for other indications which are not currently covered by the label. So this, for example, is overactive bladder syndrome or prostatic hyperplasia, and so on. So a number of new investigations and the new indications are tested. However, there is a word of caution, which is also now reflected by a black box label warning by the FDA, is that this toxin, particularly if it's not used in the face or not limited to use in face, it can spread with higher doses, and that could have systemic effects. And the systemic effect, of course, can be potentially life-threatening if that Botox spreads to sites of the diaphragm or the respiratory muscles. And this is why the FDA has now recommended that in studies that use Botox outside the face, it is a good idea and it's recommended to use pulmonary function as a safety measurement. This is not just being overcautious or some people who may be hysteric about side effects. There are, in fact, some reports about very severe side effects with the use of Botox, particularly when it's used outside the face. This is a case report on rapid, not only muscle paralysis, but also acute respiratory failure in a patient that was treated with botulinum by endoscopy because he had a sphincter problem in his stomach. So that is a different part of tolerability issue with a drug that works on the neuromuscular apparatus of the lung, so the drive of breathing, which brings us to the second part of my talk, which is the lung involvement in non-respiratory diseases, particularly in neuromuscular, but also other diseases that affect connective tissue. Now, in neuromuscular disorders, the lung can be affected in principle by two different mechanisms. First of all, there may be a disease effect on the brain and the parts of the brain that control the respiratory drive, which may result in an altered breathing pattern like Cheyne-Stokes respiration or hypoventilation, central hypoventilation, something like that. So the neurological disease affects the brain and the parts of the brain that are responsible for actually controlling the drive of breath. And the second way that these diseases can affect the lung is that they may have implications on respiratory mechanics by impairing the intercostal muscle or diaphragm function, which will then lead to peripheral muscle hypoventilation of the lung. The second big group where the lung is involved are systemic diseases, autoimmune diseases, particularly where there is connective tissue involved. And as particularly the interstitium of the lung involves a lot of connective tissue, very frequent side effects, if you like, or organ involvement of connective tissue diseases from the spectrum of autoimmunity very often involve the lung. But there are also other patterns. In principle, there may be also diseases, other systemic diseases that lead to an obstructive pattern, diabetes. We just discussed diabetes treatment, but we also know that long-standing diabetes, by whatever mechanism, also leads to obstructive airway function. So that is also something that must be considered. And there are other systemic diseases that, for example, may impact on diffusional gas exchange, or even some, let's say, general vascular diseases, which also may involve the pulmonary vasculature, leading to, for example, secondary pulmonary arterial hypertension. To start with neuromuscular diseases, one example which is very often associated with a fatal respiratory failure is ALS, amyotrophic lateral sclerosis, or now very often referred to as motor neuron disease, or in older textbooks, Charcot's disease. We had just a few weeks ago had the most prominent patient suffering from that terrible disease, which was Stephen Hawking, finally died from this disease, which is a very long-standing cause, which is unusual because most patients with the disease die much earlier. It's a progressive neurodegenerative disorder, which is pretty rare, so about 2 in 100,000 persons in the EU and US. The figures are pretty comparable for Europe and US. Unknown in cause, and well, pathophysiologically involves the death of neurons that control voluntary muscles with all the negative consequences in the end. Now, pulmonary function is very important and is a very important predictor of long-term prognosis of patients with ALS. Well, it is illustrated here in two studies that looked at the survival probability and also the probability of disease progression in two groups of patients. One group of patients that had a vital capacity of less than 75% of the predicted value, so the lung volume was decreased already by more than 25%. And the other group was a group that had relatively preserved or near normal pulmonary function. And you can clearly see that those patients with loss of lung function had a higher likelihood of dying, so survival was much worse, but also had a much higher likelihood of disease progression. So measuring pulmonary function is very important in ALS. It can be done in different ways, and for that you have to at least briefly understand the pathophysiology of respiratory impairment in ALS. So it may be that because of the muscular weakness of the diaphragm and the intercostals, lung volumes decrease, and also the inspiratory power and pressure is decreased. That is something which can easily be measured by just measuring a lung volume like a vital capacity. On the other hand, the weakness of the intercostal muscles and the abdominal wall, which is also very important for breathing, as most of us breathe using the diaphragm with support from the abdominal wall, that may also lead to a decreased volume and also particularly during expiration to a decreased expiratory pressure. And very importantly in these patients, an ineffective cough reflex. When you cough, you need support by the abdominal muscles. And if you can't cough effectively, that means one of your main clearance mechanisms of the lung is impaired, leading to a high likelihood of infection, pneumonia, which is also very often the cause of death in people who have got motor neuron disease or other neurological diseases like multiple sclerosis. There's also involvement of the glottis, which is nothing else but an apparatus of muscles. And that again, this weakness or discoordination leads to decreased forced volumes like the FEV1, but also decreased ventilatory pressures, contributes to ineffective cough reflex and also to weak gag reflex. In the end, all these factors together cause a decrease in the maximum voluntary ventilation, which is also a parameter that can be relatively easily measured in patients. Which brings us to the parameters that should be used as outcome parameters when you study ALS. So there is the best way to standardize, or the parameters that can be best standardized and have the best recommendation for standardization and troubleshooting are forced vital capacity, which is a full expiratory maneuver with maximum force. And on the other hand, the vital capacity, which is the same maneuver but without using maximal force. So slow vital capacity versus the forced vital capacity. That will give you an accurate measurement of the volume of the lung. The charm of the forced vital capacity is that it also brings you some additional information about the expiratory force, so more of the respiratory drive of the respiratory muscles. There are others that also have been used in clinical trials, like the forced expiratory volume in 1 second, or as I said, the maximum voluntary ventilation, and more sophisticated measures of lung function like maximum inspiratory pressure and expiratory pressure, which very accurately reflect the force generating capacity of all the muscles that are involved in breathing. This is a screenshot, an example of a study that used, for example, lung function as the primary outcome. This is a study on memantine in patients with ALS. And as you see on the list of parameters, forced vital capacity is in this study a co-primary outcome parameter, which is, of course, something that on first sight looks unusual. But if you look at the pathophysiology of the disease, it absolutely makes sense to study that in a non-respiratory trial. A second were more widespread neurological disease with pulmonary involvement, where this is important, is MS, multiple sclerosis. Also, these patients quite frequently have respiratory impairment, and respiratory impairment can also be a prognostic factor in these patients. And for these patients, it has been shown that you can use conventional pulmonary function tests like spirometry. However, the ability to discriminate in early stages of the disease using these parameters is not, the potential is not very big. You can see the graph on the left side that those patients, yes, who have a very severe form of MS, who are bedridden, they have marked differences in pulmonary function and percent of predicted. However, if you look at those patients who have, for example, less severe disease, who are ambulatory without assist, or who are in a wheelchair, there are very small differences only in conventional lung function parameters. However, if you, on the right side, and you use more sophisticated tests that reflect respiratory muscle function, like maximum pressure or cough reflex or something like that, then you can see these are more sensitive, also in early phases, already detecting differences in the pulmonary function, or let's say respiratory function, of these patients. So it may be more suitable and more useful in more early disease to study maybe parameters that exceed traditional lung function like spirometry, vital capacity, and stuff like that. It's also of prognostic relevance, for example, forced vital capacity. If you look at people who have low forced vital capacity, you see that there is a progressive loss of forced vital capacity over time. It's accelerated, particularly in those patients who have progressive disease. And also cough reflex on the right side is the peak cough reflex is progressively declining over time, particularly in those patients who have progressive disease and poorer prognosis. The second large group of lung involvement in non-respiratory diseases is, as I indicated already, autoimmune disease. There are different groups where lung involvement is quite frequent, like myopathies, particularly those who have an inflammatory component. That may be not only a diaphragm or intercostal muscle involvement, but also myopathies may be associated with interstitial lung disease. And then finally, there is also autoimmune involvement sometimes in pulmonary vasculature, leading to secondary pulmonary hypertension. However, the most frequent involvement is interstitial lung disease or fibrosis, which makes sense because that's the compartment of the lung which contains the largest amount of connective tissue. And as most of these autoimmune diseases affect connective tissue, it is clear that this is the primary target for organ or lung involvement in autoimmune disease. Well, as I said, this is very often reflected as interstitial fibrosis. Very importantly, and if you're not in the field, quite often it's not known. It's actually also been new to me as somebody who's not a rheumatologist or not an immunologist. Some of the lung function parameters are actually involved or are part of disease activity tools. So typical validated instruments that assess the status of these diseases in clinical reality. So for example, there is for myopathies, there is the myositis disease activity assessment tool, MDAAT. And part of that score, which in this case, whether there's more severe disease or less severe disease, diffusion capacity and forced vital capacity are a critical part. So you get a high score if your diffusion capacity is bad, and if your forced vital capacity is bad, you also get a higher score. And that, of course, has an impact on prognosis and intensity of treatment. So these are very important points also to follow up in interventions or drug development for these types of diseases. You can see here, it's maybe a bit small, but very often lung function is also used as outcome parameter in autoimmune diseases that have multi-organ involvement. This is an example for systemic sclerosis, severe systemic sclerosis, where there was a clinical trial looking at the potential effect of stem cell transplantation versus conventional medical approach. And you can see that there was some difference with stem cell transplantation in favor over conventional therapy. If you look at forced vital capacity, total lung capacity, and also other lung function parameters like DLCO have been followed up here as important or key secondary outcome parameters. And that also, again, makes sense because in systemic sclerosis, we know that up to 90% of patients develop lung involvement, and in many of these patients, lung involvement is a critical prognostic feature. So that brings me to my conclusions on this topic of monitoring pulmonary safety and disease progression of systemic diseases in clinical trials. I think I made my point. The lung is important, not because I'm a pulmonologist. That's, of course, the main issue. But the lung is also important to the non-respiratory physician. It's an important target organ, not only for systemic diseases, but also, of course, it can be an important target organ as the liver, not as much as the liver, but as the liver, for drug toxicity. And it is very often, sometimes subclinically, sometimes unnoticed, involved in systemic diseases. And it's always worth to look at potential lung involvement because that has a very important implication on prognosis for these patients. And this is why early recognition is so important because in terms of drug toxicity, this would lead to discontinuation of course, and then potentially initiation of lung treatment, or in terms of systemic involvement, this may have an impact on prognosis, or it would lead to intensification of the treatment of the underlying disease if there is lung involvement. How do I do that? Well, there are different ways to study lung involvement as part of safety assessment, but also as part of organ involvement in systemic diseases. Imaging is important, but most of all, very of highest importance are pulmonary function tests, particularly using diffusion capacity when it comes to alveolar membrane damage, which is always the case when there is interstitial lung disease. So for anything that causes diffuse parenchymal interstitial lung disease, DLCO is the best way to study. For others, it may also be simple spirometry. We're looking at lung volumes, particularly neuromuscular involvement. That can also be very important. And then, of course, other measures which may be more complicated and more costly, like CT scans or even biopsy may be relevant. The importance of pulmonary safety monitoring in trials is currently increasing because we have more, or we have a broader portfolio of pharmacological intervention. There are a lot of trials going on now with new drugs, new mechanisms, working on inflammation, smart drugs, traditional pharma drugs, but also a lot of monoclonal antibodies. There are a number of new delivery routes. The lung has always been a very attractive organ for drug delivery. All of that involves considering safety, considering lung toxicity, and considering the tolerability of the potential delivery process of a drug via the lung. In non-respiratory diseases, the involvement of the lung in these diseases is very often life-limiting. So again, that makes it a very attractive outcome parameter. And if you want to study that, you may do that in a clinical development program. And I'm pretty convinced that if you do it in a proper way, you can add value to a specific drug or a specific intervention if you impact on these absolute vital parameters. These are vital because breathing is vital for patients, and not being able to breathe correctly is life-threatening. So this should be done, of course, in a phase 3 for registration purposes using lung function parameters that are validated, established, and ideally those who can be standardized and maybe centralized to get the best quality of data in your clinical trial. And I think it's a still growing field, and I think that in the future we will have better information and more information how the impairment of lung function or respiratory function in general is an important driver of prognosis in patients that are affected by diseases that happen somewhere in the body, nowhere near to the lung, but nevertheless may have an important impact on this vital and very exciting organ. So when it comes to the lung, either when you treat or either you have a disease which at first sight may not have anything to do with the lung, it's always important. Stay safe with the lung. Thank you very much for your attention.
Thanks for that enlightening presentation, Kai. We really appreciate it. It looks like we have a couple of questions from the audience. The first one is, I have heard that DLCO testing is highly variable by site. How can you be sure that you pick up a safety signal as early as possible? Is there a concern that a safety signal like this will be missed or delayed?
Well, as I said, if you really want to study that, we capture that in a clinical trial, I think the best way is really to harmonize equipment and methodology. For DLCO, there's now a recommendation by the ATS-ERS guideline committee, and that also should be strictly followed. And the best way to make sites follow the established procedures is always to have somebody in charge who is overseeing that, and that ideally, or in most cases, will be a third-party vendor. And I think there is good evidence out there to show that if you use a centralized approach or standardized approach, you get the best of your data. On an individual level, if you are a treating physician and you are concerned because your patient is on amiodarone or something like that, if you have good quality assurance measures in your practice, I think it is possible on an individual level to follow your patient up. Maybe not on a 2% change perspective, but that's probably not clinically relevant anyway. In an individual case, you're looking for maybe a 10% change or something like that. And that is also possible in clinical practice with your own equipment, provided that you have a good quality assurance. If you want to detect a 2% signal or a 5% signal in a trial, which may be important for a go or no go for a drug, then for me there is no other way than using a centralized and a standardized approach.
Excellent, thanks. So we have another question with regards to Botox safety. What are the best assessments, FEV1, FVC, VC, or some mix of all?
I think this spirometry offers the beauty that you can measure all these parameters with a single maneuver simultaneously. As I said, probably as Botox would affect the neuromuscular drive, I would say that the measurement of the vital capacity is probably enough. It should give you a signal. However, to get the full picture, you may also want to know whether there is not just the volume, but the volume per time. So how fast can you actually generate that volume? Because that tells you something about respiratory drive and respiratory muscle function. So ideally, you would use spirometry, which will give you some force parameters, FEV1, forced expiratory volume 1 second, forced vital capacity, plus a simple inspiratory vital capacity. All of these parameters are reliable. They are consistent. They have very little variability, and we know what a meaningful change for any of these parameters is on an individual basis.
Great, thanks, Kai. Few more questions. What do you think is the best PFT parameter to study progression in neurological disease?
Sorry, I didn't get the last one. In what disease?
What do you think is the best PFT parameter to study progression in neurological disease?
In neurological disease, yeah. Well, yeah, that's something. I mean, that's a bit difficult question to answer. I think ideally you should look at something like maximum inspiratory or expiratory pressure, or something that involves peak cough reflex, as we've seen from some of the data. We know that traditional lung function parameters, are just like vital capacity or FEV1, may not be very sensitive in early stages. And if you do a long-term follow-up, these patients, you want to study progression of the disease, and get an idea about whether there is your drug works on, let's say, prevention of progression from early to moderate to severe. I would look at more sophisticated lung function measurements, some involving pulmonary force, like pressures. And that, of course, is more difficult to set up in a clinical trial, but nevertheless can be done because the maneuvers itself, the maneuvers per se, are not very difficult to perform. So I think anybody, any trained physician or any trained healthcare professional or personnel can actually learn that.
Awesome. One last question. What is your specialist experience with using a centralized PFT approach versus non-centralized in terms of overall quality?
Well, I think there's a clear answer to that. I mean, there's data out there, and it makes sense that if you go to studies beyond, let's say, whatever, a 2 or 3 center study in specialized, dedicated lung function centers. But if you go to a step, let's say you involve several hundred patients, and maybe 100 or even more sites from all over the world, there's excellent evidence to show that you dramatically increase the number of acceptable measurements, the quality of your data, so you generate power for statistics and stuff like that. So I think it's pretty clear that I would say from a phase 3 onwards, and also for many of the phase 2 trials, if you really want to have good quality PFT, there is probably, as a sponsor, no way around some type of centralization.
Great. We'd like to thank Dr. Bay for his presentation today and thank everyone again for attending today's webinar. This webcast will be posted for on-demand access in the next 24 hours, and you can email events@ert.com to request a copy of the presentation deck or for any additional questions and answers. Stay tuned on ert.com for upcoming webinars and other useful content on clinical trial safety and efficacy, as well as trial oversight, site optimization, and patient engagement to help you minimize risk and move forward quickly and with confidence. This concludes our webinar, and we hope that you have a great day.
Thank you all.